Wish you all a very good evening and welcome to the Indian Chess Society OAD webinar series. Today, we are very fortunate to have a very elite panel of distinguished pulmonologists from across the country. And I also have the privilege of giving the first talk today. But more privileged to have Dr. Professor Murali Mohan, who is going to be the moderator for today's session. This is an initiative that has been taken by the Indian Chess Society. It has been going on for a long time now, and most of these webinar series of the Indian Chess Society have been very popular. We have been always having 2,000 plus delegates to listen to this wonderful webinar. So, without wasting much time, can I have the first slide, please? If I can show the first slide, can I show the first slide? Okay, so let's have Dr. Murali Mohan for the introduction, and then I'll show my slides after that. Indeed, an honor and a privilege to introduce and invite Professor Dr. Murali Mohan to be the moderator for today's webinar series. I'm sure he needs no introduction at all. He is a highly respected pulmonologist and an academic who is based currently at the Narayana Health Muzumdar Shaw Medical Center in Bangalore. He was a very popular and highly respected head of the Department of Respiratory Medicine and professor at the B.R. Ambedkar Medical College in Bangalore. He is distinguished with several honors to his name, including lots of orations, a lot of publications. He has also been the founder of the Nightingale's Life-Saving Service, where they have trained more than 90,000 people in CPR in Karnataka. He's also been the former editor-in-chief of the Karnataka Journal of Medical Sciences. He has been the chairman of the Association of Physicians of India of Karnataka chapter and has specific interests in interstitial lung disease, pulmonary vascular disease, and sleep medicine. So without wasting much time, Dr. Murali Mohan, may I please invite you to be the moderator for today's webinar, and I look forward to this. Thank you.
Thank you, Dr. Salvi. It's over to you to give the first talk. I don't think anybody needs to introduce Dr. Salvi. He is the current president of the Indian Chess Society. He's a member of the board of directors for Gold, so there's no one better to speak to us. Not only Gold, he's also on the scientific committee for GINA. And he chairs the chronic respiratory diseases section for the GBD, the Global Burden of Disease India, and he was kind enough to invite me to be part of this group. He's a member of the Steering Committee on Air Pollution and Health for the Ministry of Health and Family Welfare. He has more than 250 published papers, and these are very high quality papers, which is, what makes it very special. He is the recipient of the American Thoracic Society World Lung Health Award 2024, and he's recognized worldwide. Stanford University, in their ranking for 2024, has ranked him the #1 respiratory scientist in India. So we're very privileged to hear him. And out of more than 66,000 respiratory scientists all over the world, he's ranked number 35. That's amazing. And we are really privileged to hear you, Dr. Salvi. And it's been wonderful to work with you for all these years. It's been such an education. Over to you.
Thank you, Dr. Murali Mohan. Thank you very much. Can I have the sharing, please? Yeah. Are you able to see my screen?
Yes, sir.
Okay. So once again, wish you all a very good evening. And let me start by welcoming you all to the much awaited National Pulmonary Conference, or NAPCON, which has now shifted from Kolkata to Pune. The NAPCON was going to happen in Kolkata. The dates were also announced, but I'm sure all of you are aware of the current situation of what is happening in Kolkata. And therefore, it was thought that it would not be appropriate to continue having the NAPCON in Kolkata. So as a result, now it is being shifted to my city in Pune, and Dr. Nitin Abhyankar is going to lead the NAPCON show as the organizing secretary. The dates are 23rd to the 26th of January. So please do join us for this amazing scientific feast, which will wait for you, and we'll have a wonderful NAPCon in Pune. So I urge all of you all to start registering for it, and make sure that you block these dates and most certainly come to Pune for our very own NAPCon. And I look forward to seeing you then. Let me start by sharing with you this very important link between the heart and the lungs. And the title that I have given for my talk is Heart Under Attack from the Lungs, and what should pulmonologists know? So I believe that this is going to be an important topic for discussion, and it will have a lot of implications on our own clinical practice. What I'm going to share with you is some very exciting work that has been done in this field, and some lots of updated knowledge which probably you would not have come across. And this will most certainly help you improve the quality of care that you would offer to your patients. So let's start. The human body is an amazing composite of more than 32 trillion cells. Somebody has even counted the number of human cells that we have, the cells that make up all the organs and the tissues of the body, 32 trillion. And each of these cells, they have to work in harmony with each other. And for that, every cell requires energy to perform its function. We all know that the adenosine triphosphate, popularly called as the ATP, is the energy currency of the cell. And this is what the cell utilizes to perform all its function. You may perhaps not know this, but on a daily basis, the human body requires as much amount of ATP that is equivalent to your body weight. So if you're somebody who weighs 60 kilos or 70 kilos, then your body produces 60 kilos or 70 kilograms of ATP every day. Obviously, it is used almost instantaneously, but that is the quantum of energy that the human body requires on a daily basis to keep itself alive and to function properly. Here is another statement. 90% of the body's energy, or the ATP, comes from the oxygen that we breathe, and only 10% comes from the food that we eat and the water that we drink. So oxygen is absolutely vital for our survival because it generates 90% of the body's energy. And in order to supply this vital nutrient to our body, nature has provided us with this beautiful organ called as the lung, which is situated in the thoracic cage. This organ nourishes our body with oxygen, and on a daily basis, each one of us who's listening to this presentation requires 1,000 liters of oxygen. And for this, we breathe around 10,000 liters of air every day. 21% of the air comprises of oxygen, and therefore we have a potential to have about more than 2,000 liters of oxygen that we can take in, but the body consumes only about 1,000 liters. There's a backup of an additional 1,000 liters in case you are performing heavy exercise, or if your body requires more oxygen, it would extract that as well. The oxygen that is extracted by the lung is then delivered to every single cell of the body through these red blood cells that contain hemoglobin. So hemoglobin is the prime carrier of oxygen to all parts of the body. And you'll be surprised to know that at any given point of time, there are 25 trillion red blood cells circulating in the blood. Now, which means that around 80% of all the body cells are red blood cells, and their only job is to transport oxygen from the lungs to all the cells of the body. Each red blood cell has 300 million hemoglobin molecules, which attach 4 molecules of oxygen to each of these hemoglobin molecules. Look at the amazing architecture the human body has in order to soak in the oxygen and to transfer it to all the cells of the body. And then the heart takes over to pump all the oxygen through the red blood cells to all parts of the body. The heart is an absolutely amazing organ. It pumps around 10,000 liters of blood every single day. So isn't it amazing that we breathe 10,000 liters of air and the heart pumps 10,000 liters of blood every single day, only to nourish the body with oxygen and then to get rid of a waste product called carbon dioxide, which is around 300 liters that need to be excreted every day. This happens through the circulatory systems, the two circulatory systems that we have in our body, the pulmonary circulation and the systemic circulation, through which all the oxygen is delivered to all the cells and carbon dioxide is collected and then pushed into the lung to be excreted. So what an amazing human body that we have. It is therefore no surprise that the lungs and the heart are probably the most important organs of the body that nourish us with this vital life force called oxygen. Strategically, they're located just close to each other, probably because of the immense collaboration that they have with each other in terms of keeping the body healthy and fit. And then the lungs and the heart actually talk to each other a lot. The lungs talk to the heart and the heart talks to the lungs. We all know that there are shared risk factors that affect both the lungs and the heart, such as tobacco smoking or exposure to air pollution that affects the lungs, that also affects the heart. Increasing age and reducing physical activity are all risk factors that affect both the lungs and the heart. But we also know that the lungs have a significant impact on the heart by these various mechanisms. So if you have a lung disease that is associated with inflammation, the inflammation then spills over into the circulatory system and then goes through the pulmonary circulation to reach the heart to cause subsequent damage to the heart. Reactive oxygen species released from the lung in various lung diseases such as COPD, asthma, and other disease states. These are also released from the lung, enter the heart through the circulatory system. We also know that the hyperinflated lungs that we have in COPD have a mechanical effect on the pumping ability of the heart, because a hyperinflated lung reduces the diastolic filling of the heart, and therefore the cardiac output can also be significantly impacted only because of the anatomical push that the lungs do to the heart. In addition to that, hypoxia also has a significant impact on the heart, and the drugs that we use to treat lung diseases also have a significant impact on the heart function. And I'm going to cover this in my subsequent slides. The other is also true, where the heart has a significant impact on the lung, in the sense that if you have a heart disease, it will also have an impact on lung function. So we all know that as the heart fails, the back pressure on the lungs increase, you can get a pulmonary edema. So it's a heart condition that is affecting the lungs. We also know that certain drugs that we use to treat heart diseases will also have an adverse effect on some of the lung function. For example, beta blockers or the ACE inhibitors that are used to treat heart conditions will also have the potential to cause harm to the lungs. Now, this is a wonderful review that Professor Leo Fabry led. I was a part of this review that was published in the Lancet Respiratory Medicine a few months ago. And it actually tells us about the beautiful story of how our understanding of COPD has changed over a period of time. We all believed that COPD was a single disease that affected the airways, primarily the small airways, and the lung parenchyma, where there was damage and destruction, which we now call as chronic obstructive pulmonary disease. And as a pulmonologist, your role was only to pick this up, make an early diagnosis, a correct diagnosis, and treat it appropriately. It is only over a period of time that we started realizing that COPD is a disease that is associated with a whole host of different comorbid conditions, conditions that affect the heart, the brain, the the endocrine system, the musculoskeletal system, and so on, associated, very strongly associated with COPD. And as a matter of fact, it's the origin from the lung disease that actually has an impact on various organ systems. So we then started realizing that COPD is not a single disease that affects the lungs. It is a disease that is associated with a lot of comorbid conditions. And then more recently, this is the latest realization that we have in the sense that COPD is a multi-morbid condition. So they're not isolated lung problem, an isolated heart problem, an isolated brain problem, and so on. It is actually a mixture of all of this. So a combination of all of these affect each other. The heart, the lungs talk to the heart, the lungs talk to the brain, the lung talks to the endocrine system, and the heart also does the same with all the organs. And it's a composite of all this that we now started realizing that it's a multi-morbid condition rather than a disease with comorbid conditions. A few years ago, we conducted one of the biggest studies ever done in India called as the Poseidon study, a one-day point prevalence study conducted in 880 cities and towns, where we collected data from 205,000 patients. And we then wanted to understand what are the reasons for which patients visit a doctor in India. And out of these 205,000 patients, doctor-reported COPD was identified in over 6,000 patients. And then we started looking for associations with COPD with other disease states. And we were surprised to see that COPD was very strongly associated with congestive heart failure, with an odds ratio of around 4.5 times, associated with ischemic heart disease, hypertension, and stroke, along with other disease states like diabetes and arthritis and anemia. So this was a big realization that if you see a patient of COPD, you must most certainly look for these associated diseases because they are very, very commonly seen. We are not the first ones to report it. In fact, this has been shown for many, many years. And this is an old study that was conducted in Saskatchewan in Canada, where they compared the prevalence of various cardiovascular diseases among those who have COPD versus those who do not have COPD. So you can see the pink bars over here, they represent COPD subjects, and the gray bars represent non-COPD subjects. And you can see that the pink bars are higher than the gray bars for arrhythmias, for angina, for acute myocardial infarction, for congestive heart failure, and so on. So COPD is most certainly associated with a whole host of cardiovascular disease states. And here is a latest systematic review and meta-analysis that was published just a few months ago of 23 studies from different parts of the world, a very large study of around 3.5 million COPD patients versus close to 31.5 million non-COPD controls. And when you do this associations, you find that COPD is strongly associated with myocardial infarction, ischemic heart disease, heart failure, and stroke. So the association between COPD and the heart disease is now well established. I think there is absolutely no doubt in our mind that COPD is associated with heart diseases. Now, this is a very interesting study published again just a few months ago. Risk of myocardial infarction in COPD patients presenting with acute exacerbations. And the bottom line is a COPD patient who presents with an acute exacerbation, if he has had one moderate exacerbation in the past, then the hazard ratio of this person having a myocardial infarction is just around 1, but that is not significant. But those who have 2 moderate exacerbations or 1 severe exacerbation or more than 2 severe exacerbations, the hazard ratio for acute myocardial infarction increases almost close to 2-fold. So if you have an acute exacerbation of COPD, the risk of you having a heart attack or an acute myocardial infarction is around 2-fold. And this is another study, a very large study from Sweden, from England, that looked at risk of cardiovascular events after a COPD exacerbation. And I just would like you to focus your attention on the orange dots over here, that tell you the risk of having a cardiovascular event soon after an acute exacerbation. So within the first 14 days after an acute exacerbation, the risk of having a cardiovascular event is around fourfold higher. And then it reduces as the duration increases. So the highest risk of having a cardiovascular event uh, in a patient who has had an acute exacerbation of COPD is in the first 14 days or in the first 1 month. It's around threefold higher than when they do not have an exacerbation. And you can see that the risk for arrhythmias, the risk for heart failure is almost 12-fold and 8-fold within the 2 weeks of an acute COPD exacerbation. So clearly there's a very strong signal that is coming out over here. It's not only COPD, but even asthma. And here is a very large study in 57,000 people that looked at the association between active asthma and the risk of having an acute myocardial infarction. So the risk is increased by around 30%. And if you especially have uncontrolled asthma, then the risk of this person having an acute myocardial infarction is increased by more than 70%. So asthma is also shown to be associated with an increased risk of myocardial infarction. And then another study published very recently more or less shows the same thing. But during an acute exacerbation of asthma, the risk of having especially heart failure is again very high. So it's not only COPD exacerbations, but even asthma exacerbations are associated with heart failures and acute myocardial infarctions. Now, this is another study that also looked at the use of short-acting beta agonists, either through an MDI or a nebulizer, and its association with hospitalization for congestive heart failure or all-cause death. And you can see that as the average number of canisters filled per month increased, the risk of being hospitalized for congestive heart failure and the risk of dying from any cause increases significantly. So increased use of short-acting beta agonists is associated with congestive heart failure, associated with all-cause death. And I think this was an important observation that was made more than 20 years ago. But here is a very interesting study that was published a few years ago. Inhaled beta-2 agonists in patients who are admitted to the ICU with heart failure. And this is a very interesting and a very important study conducted in the city of Guangzhou in China, where they collected a database of more than 2,300 patients with heart failure who were admitted to the intensive care unit. Now, they just looked at those who received a beta agonist versus those who did not receive a beta agonist in the ICU setting among patients admitted for heart failure. And this is what they found. Close to 50% of patients with heart failure were being treated with inhaled beta-2 agonists, either nebulized salbutamol, the most common drug that is used. And of these, only half of them actually had an underlying lung problem, such as asthma or COPD. So the use of a short-acting beta agonist in an ICU setting among patients with heart failure is pretty high. Half of them receive it, even if they don't have underlying asthma or COPD, because many of us believe that patient with heart failure having shortness of breath, wheeze, would probably benefit by the use of nebulized salbutamol or a nebulized short-acting beta agonist. But here is the key observation. Use of beta agonist was associated with almost a 2.5-fold greater odds of dying among these patients who had a congestive heart failure. So this is important. This is really important. Beta agonists in patients with heart failure can cause death. And this death, the risk of death increases by 2.5 times, especially in this setting. So all of us know that the lungs can have a significant impact on the heart through various mechanisms. I talked about inflammation. I talked about oxidative stress. I talked about the inflammatory mediators and the cytokines released from the lung entering into the heart, causing damage. But the importance of hypoxia and the treatment that we use for lung disease having a significant adverse effect on the heart has not received as much attention as what I think it should have received. And the subsequent part of my presentation is going to focus on these two elements, hypoxia and the drugs that we use to treat lung disease. Now, let me share with you some absolutely amazing facts about the heart. It's a very small organ, the size of a fist, weighs only 330 grams. It beats around 100,000 times a day. And as I said earlier, it pumps 10,000 liters of blood every single day. Now, nature has gifted this organ with the ability to burn anything and everything under the sun. Therefore, it is called as a metabolic omnivore. The heart can burn any fuel that it has access to. It is gifted with the ability to do that. It can use glucose, fatty acids, amino acids, ketones, lactate, everything to generate energy. There is no other organ in the body that has got this freedom to burn anything under the sun. It's only the heart that has been given this wonderful property. And the reason is quite obvious, because if the heart stops pumping, we are dead. So it cannot afford to stop beating. Therefore, it needs to generate energy for all this. Given a choice, the heart prefers to burn free fatty acids. And the logic is very simple. If you burn one molecule of glucose in the absence of oxygen, what we would call as anaerobic glycolysis, it generates two molecules of ATP. But if you burn the same molecule of glucose in the presence of oxygen, what we call as oxidative phosphorylation, it generates 36 molecules of ATP. So look at the amplifying power of oxygen. If you burn one molecule of fat, it produces a huge amount of energy, 132 molecules of ATP. But there is a caveat for that. If you want to burn fat, you have to have a lot of oxygen available. It is only then that you can burn the fat to generate energy. So it's something like driving a Ferrari. So if you have plenty of petrol, you have no shortage of petrol, you can drive a Ferrari because petrol is very easily available and freely available. But if the availability of petrol is less, you want to improve your your mileage, then you would have a Maruti car. It travels the same distance, maybe slower, but it travels that same distance. And if you have no petrol available, you can still go with a bicycle. It doesn't need any petrol. So that's glucose, anaerobic, glucose aerobic, and free fatty acids. Now, here are some absolutely amazing properties of the cardiomyocyte. If 100 ml of oxygen enters into the coronary vessel, only 15 ml exits, which means that the cardiomyocyte has the ability to extract 85% of the oxygen that flows through the vessel. It is the only organ in the body that has got this immense ability to soak in so much of oxygen. The organ that comes number 2 is the kidney, and it extracts 15% of the oxygen. Look at the gap between the heart and the kidney. And all other organs of the body, which is a skeletal muscle, your brain, and all other tissues, they extract between 5 to 10% of the oxygen. So the cardiomyocyte is a very special cell that has the ability to extract a lot of oxygen. The other feature is, if you look at the electron microscopic feature of a cardiomyocyte, 50% of the volume is made up of mitochondria. And that is absolutely necessary if you want to burn a lot of oxygen and if you want to use fat as a fuel substrate for that. So plenty of oxygen can be extracted by the cardiomyocyte. It has got lots of mitochondria, constituting 50% of the volume of the cell, and therefore it can produce a lot of energy. That's the beauty of this cardiomyocyte. The more interesting understanding is the amount of oxygen that is available decides which fuel the heart should use. So on the left-hand side, you can see the coronary vessel patency, 100% patent, 50% patent, 10% patent. If the coronary vessels are patent, then the cardiomyocyte prefers to burn free fatty acids because there is a lot of oxygen available. When there is blockage in the coronary vessel and the oxygen availability becomes less, it switches the fuel from free fatty acids to aerobic glycolysis. And when the availability of oxygen diminishes significantly, which is seen in if you have a 90% block in a coronary vessel, then the myocardium relies only on anaerobic glycolysis to generate that energy. So here is a fact that is important for us to understand based on the availability of oxygen. Now, you don't need to have blocked coronary arteries because hypoxia itself can also have a significant impact on the fuel that the heart uses. So if you have a lung problem like COPD, or you have a lung problem like asthma, then a diseased lung would soak in less amount of oxygen. And therefore, there would be hypoxia in the systemic circulation. Now you can see here the SpO2 on the y-axis and the PaO2 on the x-axis. So even when the PaO2 reduces by 40 millimeters of mercury, the SpO2 drops only by 10%. So in spite of having significant hypoxia, the SpO2 doesn't pick it up. And the reason why I'm telling you this is if there is a lung problem, if there's a lung disease, which is not soaking in a lot of oxygen, then the heart will need to switch its fuel to glucose. There is something called as MINOCA. I do not know how many of you all have ever heard this term, MINOCA, myocardial infarction in non-obstructed coronary arteries. It's a very interesting concept where you don't need to have any coronary blocks to have an acute myocardial infarction. Even in the presence of patent coronary arteries, you can have myocardial infarction. And not surprisingly, you can see that COPD is one of those factors, the risk factors associated with MINOCA. So even if you have patent coronary arteries, patients of COPD can still develop a MINOCA. And the odds of them developing that is about more than 60% increased odds. Diabetes is also associated with increased risk of having MINOCA as compared to those who do not have diabetes. So this is a very interesting concept, which has been in the literature for the last 5 years, something very exciting. Let me share with you another very exciting fact. Charles Murray was a pathologist at the University of Washington, and he was looking at what happens to the myocardium energetics when you block the coronary artery. So here you've created a block. The pink is the blood flowing through the coronary artery. The black is the thrombosis in the coronary vessel. Massive thrombosis gives rise to an acute myocardial infarction where you get dead tissue. So the size of that infarct is 70%. Now, if the same person, you give repeated episodes of ischemia, followed by the same block, by the same thrombus, the hypothesis that Charles Murray had was that the infarct size would become bigger than 70% because you already created multiple episodes of ischemia and then you had an acute blockage of the coronary vessel. But something opposite happened. The size of the infarct was only 15%, much less. So the repeated episodes of ischemia, clinical equivalent to that is repeated episodes of angina, followed by a massive thrombosis, will give rise to a smaller infarct compared to those who did not have those previous anginal episodes. This phenomenon was called as ischemic preconditioning and is now recognized as the most powerful protection mechanism of the heart to date. There is nothing more powerful than the process of ischemic preconditioning to protect your heart from having a bigger myocardial infarction. So here is the bottom line. In a healthy state, when there is plenty of oxygen available, the heart prefers to use free fatty acids as the fuel. When there is hypoxia, when there is a lung disease like COPD, or when there is ischemia, the heart then switches its fuel from free fatty acids to glucose. And this actually protects the heart from an ischemic damage. As I said, this is called as an ischemic preconditioning. But who controls the switch? Whether I should use free fatty acids or whether I should use glucose, who decides that? And people have been trying to find out the molecular mechanism of the switch that tells the myocardium to start using glucose when there is less amount of oxygen available. A lot of research has been done to find out who actually does that change in the switch. So this is an article that I published more than 20 years ago in Chest, where I made an argument for who that switches. The switch are the adrenergic receptors, alpha adrenergic receptors and the beta adrenergic receptors. So for example, in a blood vessel, alpha adrenergic receptor stimulation causes vasoconstriction, but beta receptor stimulation causes vasodilatation. So there are two opposites. Alpha is opposite of beta. The same thing happens in the smooth muscles in the airways. So alpha stimulation causes bronchospasm, beta stimulation causes bronchodilation. The same receptors are present in the heart, and stimulating the beta adrenergic receptor actually forces the myocardium to use free fatty acids. And for that, you obviously need to have plenty of oxygen that is available. So the molecular mechanism of using free fatty acids to generate energy is mediated by the beta adrenergic receptors. When there is presence of hypoxia or ischemia, the beta adrenergic receptors go inside the cytoplasm and the alpha adrenergic receptors get expressed. And now stimulating the alpha adrenergic receptor produces energy through the breakdown of glucose. And this actually protects the myocardium from an ischemic damage. So patients who have a lung disease like asthma, COPD, or any chronic lung disease, where oxygen is not collected in adequate amounts from the lung, then the heart starts using glucose as a fuel instead of free fatty acids. And this is actually dictated by the receptors that are present on the myocardium. Now, what this boils down to is the fact that if there is hypoxia or there is coronary artery disease, then stimulating the beta adrenergic receptors would actually be harmful because there is less oxygen available. You're still forcing the myocardium to use free fatty acids when it is not able to generate that energy because there is less oxygen available. So beta stimulants will actually cause damage to the myocardium. And the contrary is beta blockers would actually protect the myocardium from an ischemic damage if there is underlying hypoxia or a coronary artery disease. The opposite is also true. Alpha agonists will protect the heart. Alpha blockers will make the ischemic heart disease worse. Now, why am I showing you all this? I'm showing you all this because stimulating the beta adrenergic receptors in people who have got an underlying lung disease like COPD would actually have a harmful effect on the heart because you are forcing them to burn free fatty acids when there is not enough oxygen available. And the other holds true as well, that giving beta blockers in patients of COPD with an underlying hypoxia or an underlying coronary artery disease is going to protect the myocardium because you're now shifting the fuel from free fatty acids to glucose. And this, I believe, is the cornerstone of what I'm going to show you in the subsequent slides. So here are the beta receptor stimulants. You have the full agonist, the partial agonist, you have the neutral antagonist, and then you have the inverse agonist. Why am I showing you this? The higher you are on this list, the more damage it is going to cause to the myocardium, especially if you have a hypoxic state or you have a coronary artery disease state. So isoprenaline and formoterol would be the beta stimulants that would cause more damage to the myocardium. Salbutamol, salmeterol, indacaterol, vilanterol are partial agonists. So on a relative basis, they will probably cause less harm to the ischemic myocardium. And then on the other hand, metoprolol, bisoprolol, nebivolol, carvedilol, which are all, we call them beta blockers. They're actually inverse agonists. They're the ones that will protect the myocardium from ischemic damage. And to support this, this is a very interesting study conducted by Maria Cazzola from Italy, where he collected these 12 COPD patients who had underlying hypoxia, and he gave them a single dose of either a placebo or a salmeterol of 50 micrograms, formoterol of 12 micrograms, or formoterol of 24 micrograms, a single dose. And then he did a Holter for 24 hours. And you can see that compared to placebo, there are more ventricular premature beats in people who received salmeterol, and formoterol actually had more than the effect produced by salmeterol. So formoterol at a dose of 24 micrograms, a single dose, was able to produce more ventricular premature beats, multiform premature beats, and paired ventricular premature beats. Just to highlight the fact that they do have a significant impact on the myocardium. We are all aware of this story in the 1960s and the 1990s, where high doses of isoprenaline was associated with asthma deaths. High doses of phenoterol, especially in New Zealand, was associated with increased asthma deaths. And then the association between the sales of phenoterol on the right-hand side versus asthma deaths. So as the sales of phenoterol reduce, asthma deaths reduced, clearly highlighting the fact that use of beta agonists among patients with asthma cause a lot of death. And I believe that a significant number of these could be because of the impact that it had on the myocardium. A very recent study that looked at potential mechanisms between heart failure and COPD using bioinformatics. And this is a very sophisticated way of looking at things. But there is something called as the digital signature database that contains gene sets that are impacted by various drugs. There are about 22,000 gene sets that are currently available. And when we look at COPD with heart failure, these drugs pop out as important drugs that have a significant impact on the genes that will switch on heart failure. So you have salbutamol, you have isoprenaline, and then you have orciprenaline, which I've underlined. So clearly bioinformatics also telling us the same story. Here is a systematic review and meta-analysis of 20 studies published this year about the role of beta blockers in patients with COPD and associated cardiovascular comorbid conditions. And the bottom line is, use of cardioselective beta blockers is associated with a 50% reduced risk of death, 50%, and 24% reduced risk of exacerbations of COPD. So look at the therapeutic benefit of a beta blocker in patients of COPD who have an associated cardiovascular disease. What is important is to appreciate the fact that you need cardioselective beta blockers. So here is the list of the cardioselective beta blockers at the bottom. You have atenolol, betaxolol, bisoprolol, bitoprolol. These are all cardioselective beta blockers. Nodelol, propranolol, timolol, sotalol are non-cardioselective, and therefore they will likely cause more bronchospasm in these patients, and therefore they should be avoided. So if you have to use a beta blocker, use a cardioselective beta blocker. Should you use or should you not use it? If you don't use it, then there's a 50% increased risk of them dying from an associated heart condition. And I think that's a very, very significant problem. One of the last slides, real world effectiveness of medications on survival in patients with COPD heart failure overlap. 23 million people from Taiwan, and look at that number of COPDs, 1.16 million COPDs. There are four graphs over here. You can see the dotted line, and then you can see the black dots next to that. If the black dots are to the right of the dotted line, it shows that it is causing harm. And you can see that with SABAs, and you can see that with LAMAs. The lower two graphs, you can see that the black dots are to the left of the dotted line, which means that there is a beneficial effect of these drugs in patients with COPD and heart failure. And these are the cardioselective beta blockers and the LAMAs, which have been shown to be beneficial or safe in patients with COPD and heart failure. Now, why am I showing you all this? If you have a patient of COPD who has associated heart failure, who has associated myocardial ischemic heart disease, who has associated coronary heart disease, be very, very careful in giving them beta agonists. I think that's the main carry-home message that I would like you to take from my presentation. Here is a very nice study about electro-ECG changes in patients of COPD. And please, those postgraduate students, please take a picture of this and do read this paper. Beautiful study that tells you what are the ECG changes that occur in patients of COPD. And this is contributed not only by hypoxia, but the drugs that we use to treat the COPD, and how the drugs can have a significant adverse effect on the functioning of the myocardium. So I'm going to stop over here. The key carry-home message that I would like you to take from my presentation is the heart and the lungs, they talk to each other a lot. Be careful in giving beta adrenergic agonists in these patients, because it is going to cause, it has the potential to cause harm. Do not deny a beta blocker in a patient with COPD and associated cardiovascular disease, because if you deny a beta blocker with the fear that it will cause bronchospasm, you will cause increased death rates in our patients because you're denying them the benefit of a beta blocker. So I'm going to stop over here. and I'm going to pass it on to the moderator for today, Dr. Murali Mohan. Thank you for giving me this opportunity. Dr.
Thank you,
Mohan.
Salvi. That was absolutely brilliant as usual. I love the way you took us through from the very basics of how many red cells are there and what they do, to the molecular basis of the use of beta blockers and the fuels that are associated with the oxygen levels, ambient oxygen levels, and the patency of the coronary vessels. Absolutely fascinating. Let's go on to the discussion. We will be repeating some of this, and I think it bears repetition because these are important messages that we want to drive home at the end of this talk, because the heart and the lungs are very intimately connected. We are actually doing some work on this, trying to use AI to look at the interactions of the heart and the lung and how one affects the other. And hopefully we'll come out with something that will be a new way of looking at cardiopulmonary interactions. That's probably a couple of years in the future. We've just started the work. So I'd love to discuss this when we've got a little further with Dr. Salvi and get his inputs, maybe in about a year's time or year and a half's time. So we have a fantastic group of panelists today. Let me start by introducing Dr. DJ Christopher. Professor Christopher is a senior professor of pulmonary medicine from CMC Vellore. He's the chair of the Scientific Advisory Committee of ICMR. He's the director of the World Allergy Organization, and CMC Vellore, you know, is always a center of excellence in everything. And the Department of Pulmonary Medicine leads as one of the finest departments. He's the PI and the ICMR Collaborating Center for Excellence in Research, in TB research. He's the research chair for the Indian Chest Society and the course director for one of the research projects that ATS conducts, ATS MECOR India. He's got multiple memberships, fellowships, and awards, including the Stanford University World Top 2% Scientist list, joining Dr. Salvi on that. He's won the Best Researcher Award from the MGR University in Tamil Nadu, a Grand Challenges Awardee in 2012, and he is currently the research chair of the Ida Scudder Endowed Department in CMC Vellore. Multiple qualifications, and one of the nicest people I know, one of the most ethical people I know. So welcome, Dr. Christopher. Our next panelist is Dr. Gayathri Devi. Anybody who's been in Chennai attending the programs there knows she's one of the live wires of that program. She's the coordinator of the Department of Pulmonary Medicine in Apollo Hospitals in Chennai. She did her undergrad and postgraduate at the prestigious Madras Medical College, which is definitely at least the second oldest, if not the oldest medical college. The Kolkatans and the Chennaites argue about which came first, but it is a very prestigious institution. She has multiple awards and achievements. Most importantly, she has been faculty at many of the conferences and the joint organizing secretary of BronchoCon. She has over 30 publications, several book chapters, at least 4. And in the most recent, she's been the organizing secretary of the PG training program and the scientific committee chairperson for ATICON, the Apollo Thoracic Interventions Conference. So we're very privileged to have you, Dr. Gayathri. Welcome. Our next panelist is from my own city, a good friend of mine, Dr. Pragati Rao. She heads the Department of Respiratory Medicine at Ramaiah Medical College. She has a lot of teaching experience, UG and PG students, and she has a very special interest in both interventional pulmonology and research, where she collaborates with the very prestigious Indian Institute of Science. Welcome, Dr. Pragati. And last but not least is Dr. Athul Francis. He's from the MAJ Hospital in Kochi, a consultant pulmonologist there. He did his MBBS at Father Muller's at Mangalore and his MD Respiratory Medicine at the BJ Medical College in Pune, where Dr. Salvi was also faculty. Also got his DNB Respiratory Medicine, has undergone training in allergy and immunotherapy, sleep medicine, and holds multiple memberships. So welcome to this wonderful panel. And let's kick off with the first question to Dr. Christopher. Before we start, can I just remind you of what Dr. Amita has suggested to us, that we all keep our answers crisp, short, 1 minute, no more. She was generous to say 1.5 minutes. I'm going to keep it to 1 minute because we already have several thousand logins. I think we have more than 1,500 logins at this point. Aditi can tell us that soon. And a lot of questions are already coming in on the chat. So I'd like to give audience, our listeners also a chance to ask a lot of questions. So let's keep it crisp and quick. Dr. Christopher, what are the common cardiovascular complications associated with COPD? And what are the mechanisms of these complications?
So let me start by stating that heart disease is the leading a leading cause of death in COPD patients. One would intuitively think that patients die of exacerbations, respiratory failure, but a major chunk actually die of heart disease. Now, secondly, they are prone to pulmonary hypertension, group 3, because of sustained hypoxia that COPD leads to. And the prevalence is believed to be anywhere between 25 to 90%, but accurate figures are not available as the patients on whom these studies are done, usually right heart catheterization, are all severe people. Often they are waiting for transplant and so on. Thirdly, very closely related to pulmonary hypertension is cor pulmonale. We'll talk about it a bit later. And then a range of arrhythmias. Now, arrhythmias because of hypoxia, because of acidosis that COPD patients have, and there are several comorbidities, including cardiac comorbidities that coexist with COPD. Then these people are on beta-2 agonists, which again can trigger arrhythmias. And I came across an interesting paper that said that ventricular diastolic dysfunction, which occurs because of right ventricular overload, is one of the causes of arrhythmias. And last but important to say, azithromycin, which we give for, we give as short courses, but we also give longer courses of that in patients who are very prone for infections. So that's another factor. And Dr. Salvi already talked about the impact of COPD exacerbation in several cardiac events. So I'm just going to skip that in the interest of time.
Thank you, Dr. Christopher. This is something that's often forgotten, the point that you mentioned last of all, that diastolic dysfunction, which leads to group 2 pulmonary hypertension, is also a very important thing that we need to look for. And when a patient comes to you with breathlessness during an acute attack of an acute exacerbation of COPD, it's tempting to say it's an acute exacerbation, but very often it's pulmonary edema, secondary to either systolic or diastolic, or combined heart failure with reduced and preserved ejection fraction. So that's something we should not forget. And of course, another very important cardiovascular comorbidity that's often forgotten is pulmonary embolic disease. So a lot of patients, we're going to come to that later, is another very important complication occurring, I think, in 9 to 10% at least of patients with an acute exacerbation. So these are all, as you say, important things we need to look for, and not forget that cardiovascular disease is the prime killer in patients with COPD, and not, as you emphasized, respiratory failure or the accompaniments of an acute exacerbation. Thank you for that. So the next question I have is for Dr. Gayathri. Dr. Gayathri, how does COPD specifically affect heart health and increase the risk of cardiovascular diseases? So I'll remind you, there is cardia and there is also vascular. And the specific question that I want to pose to you, because Dr. Salvi and Dr. Christopher have completed, several aspects of this, what role do inflammation and smoking play in this relationship between COPD and the heart disease?
So COPD, as all of us know, it's a kind of a inflammatory pathology happening there. It's not only confined only to the lungs, it's also affecting the vasculature. There are a lot of inflammatory mediators being released. There's the question of hypoxia happening. And also at the same time, when this hypoxia happens, it's also stimulating the imbalance between the pulmonary vasculature, which also contributes to pulmonary hypertension. So it's a kind of a vicious cycle which is happening inside the body system, which really triggers off an inflammatory response in the body. And this really contributes to the episodes of exacerbations happening. And some of these also have an impact on the cardiovascular health as well. When there is hypoxia, obviously there's going to be more myocardial injury going to happen, and it contributes to the COPD association with the cardiovascular disease. And some of the points I think Dr. Salvi has also mentioned more in detail, so I think I can skip that part of it actually. And in addition to all the drugs that we use for the management of COPD, that also contributes to cardiovascular impact, the arrhythmias. So all those things have to be kept in mind in the relation between the COPD and its contribution to cardiovascular injury.
Great. Thank you so much. And of course, smoking has its effect on the endothelium, and endothelial dysfunction underlies a lot of these problems. And we'll come back to this later, I think, when we are talking about the therapeutics of this condition. But we must never forget the important role that the endothelium plays in preserving health. And when it's dysfunctional, smoking is one of the big triggers of endothelial dysfunction. That triggers off a lot of problems, apart from the spillage of inflammatory mediators into the system, as you just said. But one of the key things that happens in COPD, and Dr. Salvi already highlighted some of this, Dr. Pragati, is hypoxia. So how does hypoxia in COPD patients affect heart health? What are the effects of this hypoxia?
One most important thing is hypoxia in COPD and its impact on heart health. There is a complex relationship between hypoxia and heart health. One way it affects is first is pulmonary hypertension. So when there is remodeling of the vessels, there is pulmonary hypertension and ultimately it affects the heart. Then the pressures again falls back to left ventricle, it dilates, then hypertrophies, and then cor pulmonale. Another point I would reflect is increase in the heart rate. That happens because of the hypoxia, which stimulates the sympathetic system. So once sympathetic system gets stimulated, heart rate is more, and that causes a burden again on the cardiac function. And thirdly, hypoxia leads to arrhythmias and electrolyte imbalances. So again, a load on the heart, atrial fibrillation being more common, and ventricular fibrillation is life-threatening. A systemic effect of hypoxia is again, as you suggested, sir, endothelium dysregulation. That leads to atherosclerosis and again increase in blood pressure. It causes stroke and myocardial ischemia. So these are the common side effects of hypoxia.
Thank you. I'm very grateful. All panelists have been so precise in their answers, completing it within 1 minute. Let's keep this going. I mean, this is absolutely terrific. One of the other things, of course, that hypoxia does in a few patients is it causes polycythemia. So that leads to increased blood viscosity with its effects on flow, on vascular resistance, and so on. And of course, the increased risk of clotting, both in the systemic and pulmonary circulation. So all these are important effects that occur in patients with COPD. And of course, something that Dr. Salvi pointed out, and that was new to me, Dr. Salvi, thank you, that when you move into the more degrees of hypoxia, we always knew that it moves to anaerobic glycolysis, only the glycolytic phase, and it doesn't move into the tricyclic acid phase, the citric acid cycle. So one of the things that accumulates is, of course, lactic acidosis, lactic acid as a side effect of this, and that will add to the effects of hypoxia by worsening the acid-base balance and consequently the electrolyte changes. Dr. Athul, how does the use of bronchodilators in COPD management affect the heart rate, the BP? And would you use LABAs or SABAs in somebody who's got tachycardia or arrhythmia? Either one or neither?
All right, sir. So basically, as we all know, when SABAs are used, like salbutamol inhalation or a nebulization is used, it has a propensity to cause tachycardia as well as hypokalemia. So especially if it is a patient who is having a cardiac failure or he is a cardiac patient, in such cases, it will worsen his arrhythmia. It can also progress to a heart failure, or he can have a sudden ischemic heart disease as well. And with reference to the long-acting LAMAs or the long-acting muscarinic antagonist or or the LABAs, there was data that it is safer than your SABAs. When you are using acute salbutamol or salbutamol, the LABA is way better. And even among LABAs, as Sir rightly pointed out, we are seeing that salmeterol or the newer ones like vilantrol are have a higher beta 2 receptor sensitivity or receptor binding. Therefore, the cardiac side effects due to these beta agonists will be less. And similarly, LAMA, the safety profile, especially the newer upcoming LAMAs, the ultra LAMAs, they have higher propensity for your M3 receptors than your M2 receptors. So in that way also, there is a cardio safety which is there. So especially when we are using salbutamol or SABAs in a COPD patient with a heart disease, we should be extremely careful because it can cause not just arrhythmias, but even hypokalemia and other things. Because many of the times, the cardiac patients are already on diuretics and they already have a propensity to electrolyte abnormalities. So this will be just compounding the risk.
Absolutely. Excellent answer. I think you've covered every aspect of it. The key message is use caution when you're using beta agonists in a patient with COPD, and preferably use something which has a very high specificity for the beta receptors and binds to them for a long time. Vilantrol is probably one of the safer LABAs, ultra LABAs that we use these days. Back to Dr. Sundeep Salvi, who started us off. Now, we have patients with COPD. How important is it to screen for cardiovascular disease in them? And if it is important, how would you screen for them? When would you screen? Right in the beginning when you make a diagnosis or when they're in a more advanced stage? And how often would you screen?
Very good. So if you remember, Professor Christopher did mention that you can get a cardiovascular disease association in up to 90% of patients with COPD, up to 90%. So I think it is therefore imperative that every patient of COPD must undergo a cardiac evaluation. Could be an electrocardiogram, could be a 2D echo, or anything else that is associated with that, perhaps even an angiogram. So evaluating a COPD patient for a cardiac state condition is absolutely necessary. Let me show you the converse as well. We did a study in patients visiting the cardiology department at BJ Medical College. So this is a long time back. And all the patients who had an ischemic heart disease or associated hypertension, we did spirometry on all of them to find out what proportion of them actually have an underlying lung problem. And the answer is about 30% of them showed evidence of underlying COPD. And 99% of them were not aware or they were not diagnosed to have an underlying COPD. So I think that itself speaks volumes that we miss a lot of these cardiac disease states in patients with COPD, and the cardiologists miss a lot of COPD in patients with underlying heart disease. So it's important to realize this. I think the main carry-home message today is every patient of COPD must be investigated for an underlying heart problem. I think that's the key message.
And vice versa, every patient with heart disease must be investigated for COPD.
Absolutely.
We did a similar study. One of your co-Punekars, Dr. Gayathri Ekbote, did it for us.
Okay.
501 patients, consecutive patients with heart disease, coronary artery disease proven. 28%, if I remember right, had COPD. But the interesting thing was many of them had just group 1 and 2 COPD according to spirometric criteria. 50% with mild disease also have an increased risk of heart disease.
Yeah.
So look for heart disease even in mild to moderate COPD, but also look for COPD in patients with coronary artery disease. Great message. Dr. Christopher, what is the relationship between COPD and the development of pulmonary hypertension in carpulmonale? You touched on it earlier, but I'm going to request you to talk in greater detail about it. And if there are comorbidities of COPD, does the probability of developing pulmonary hypertension increase?
You're muted, Dr.
You're
Christopher.
muted, Dr. Christopher.
Sorry. So let's start with pulmonary hypertension. Now, pulmonary hypertension is defined as mean pulmonary artery pressure of more than 20 millimeters at rest. That's important because things change with exercise, and measured with right heart catheterization. Now, echocardiogram is a surrogate measure of pulmonary arterial pressure. It's never as good as right heart catheterization, but that's the most pragmatic and practical thing that we have. But when we are pushed to the corner and when we really need to know, we would use select patients for right heart cath. Now, pulmonary hypertension is deemed to be severe when it crosses 35 millimeters mercury. Now, what is reassuring is that in COPD, people seldom cross that mark. So most patients have mild to moderate pulmonary hypertension, mild to moderate pulmonary hypertension. And unlike people with, let's say, group 1 pulmonary hypertension, they would not have higher pressures. Second, carpulmonal is really a step further down. When these pressures impose strain on the heart muscles, the right heart particularly, resulting in hypertrophy and dilatation, and also impair its function, then we would call this carpulmonale. So not just COPD, but several conditions that fall within the causes of group 3 pulmonary arterial hypertension, such as ILD, sleep apnea, and so on, are also responsible for pulmonary hypertension as well as carpulmonale. Now, the second part of the question was about other comorbidities. Indeed, they are important. For example, sleep apnea is a well-recognized comorbidity of COPD. And in its own right, it can cause pulmonary hypertension and even carpulmonale. So that is the important factor. The second factor is that, we know that smoking causes COPD, but not just COPD. It causes other conditions. And one of them that is important in this context is interstitial lung disease, what can be called smoking-related interstitial lung disease, or SRILD. What are the types that can, categories that fall within this? Pulmonary Langerhans histiocytosis, respiratory bronchiolitis or RBILD, desquamative interstitial pneumonitis, and IPF itself. IPF itself can occur more frequently in smokers. And of course, the important entity called combined pulmonary fibrosis and emphysema. So all these factors can increase the risk of pulmonary hypertension or carpulmonale.
Thank you. And of course, the coexistence of any two of these conditions increases even the severity of the pulmonary hypertension. As you mentioned, with COPD, you usually get only mild, rarely moderate. But when you have two of these conditions together, the chances that you will get more severe PH is much higher. So thank you for that, Dr. Christopher. We move on to another very important problem. We mentioned it earlier, is venous thromboembolism. So Dr. Gayathri, is the risk of VTE, venous thromboembolism, which includes both DVT and pulmonary embolism, is it increased in patients with COPD? And what are the recommendations to prevent VTE in patients with COPD and for the treatment of venous thromboembolism? And we're talking about both in the stable state of COPD, do you have to do anything, or only during an acute exacerbation, do you have to use this prophylactic or treatment regimes?
See, this venous thromboembolism is more related to the disease process itself. There is a person with COPD is going to be less mobile. There's a more chance of venous stasis happening. So more chance of venous stasis in the lower limbs, more chance of DVT happening. And also it's a state of hypoxia also. And also all these inflammatory mechanisms also leads to a thrombotic state. So they are more prone to venous stasis and vascular thromboembolic phenomena. So unfortunately, this pulmonary embolism becomes a very big cause of death in patients with COPD. Maybe up to about 25% of deaths may be related to pulmonary embolism itself. So that has to be identified. The patient is hypoxic, the patient is not mobile, the patient might be obese. So all these risk factors lead on to the propensity to develop a pulmonary embolism. So that is an important thing we have to remember. And with regard to the treatment aspect, these patients should be initiated on anticoagulant therapy earlier on in their hospitalization and doing exacerbations, maybe as either an unfractionated heparin or low molecular weight heparin. So this is something which we should advocate and remember to start for these patients, because it does really play a big role in the therapy, as well as prevents this fatal complication actually of venous embolism. With regard to the newer anticoagulants, that has to be taken with a pinch of salt, how long to give, what to give, and when do we stop it. So we should be, I think, more focused to be treating the COPD, the exacerbations. The patient has some other conditions coexisting, like some hypoxia-related arrhythmias that has to be treated. If there's some coexisting arrhythmias like an atrial fibrillation, obviously that will be a call for that we have to give the patient anticoagulants. And the patient is having a pulmonary hypertension, that also, is it per se a pulmonary hypertension, or is it some complication which happened due to the COPD, something like a chronic thromboembolic phenomenon, and is that a vicious cycle which is happening internally in the system? All those things have to be kept in mind when we are treating patients with a COPD and exacerbation with the suspicion of pulmonary embolism. So definitely we have to anticoagulate our patients, especially during the infective exacerbation period of treatment.
Excellent. So two main messages there. During acute exacerbation, use thromboprophylaxis with either unfractionated heparin or low molecular weight heparin, unless there's a contraindication. In the stable state, there's no evidence for it. But during an exacerbation, please use it very, very early and don't risk pulmonary embolism, which can lead to can occur in almost 10% of patients as an acute exacerbation and can cause death in up to 25% of patients. That's the message you gave us. Thank you. Dr. Pragati, what's the relationship between COPD and the development of chronic thromboembolic pulmonary hypertension? We're moving from acute pulmonary embolism, which Dr. Gayathri told us about, to the chronic pulmonary embolism.
So for COPD, having a direct effect on chronic thromboembolism is not direct. It is an indirect effect, like chronic effect of COPD can contribute to the development of chronic thromboembolism. And chronic thromboembolism is directly related to pulmonary hypertension. So muscularization of the vessels, then hypoxemia causing vasoconstriction, then acute inflammation leading to increase in the IL-6 causing increase in fibrinogen and causing coagulation. So that is another third cause for the chronic embolism. Then the immobility of the patient. That also leads to recurrent thromboembolism. Differentiating both the disease is little dicey because COPD comes with breathlessness, chronic thromboembolism comes with breathlessness. So making a diagnosis is very challenging.
Absolutely, completely agree. And that's one of the most difficult things we find, but it should not be forgotten. And of course, this is also a very difficult group to treat the CTEPH, the chronic thromboembolic pulmonary hypertension, because they already have very significant lung disease. And very often we have to manage them medically, or we try balloon pulmonary angioplasty, but they tolerate surgery very poorly. Dr. Athul, back to you. In a patient with COPD, what are the symptoms and signs that will tell you this person is going on to heart failure? And here we're looking at both the right heart and the left heart.
So basically, so many of the times what happens is there are COPD patients who walk into your OPD and sometimes they might not be in exacerbation. I mean, you look at their baseline saturation, the baseline saturation itself may be low. And secondly, the findings which directly gives you a clue of a cardiac etiology is mostly they will have a facial puffiness. They will have bilateral pedal edema, which is pitting pedal edema. They might have an ascites or a hepatomegaly, which is there. Patient will also have symptoms. In symptom-wise, they will have symptoms like orthopnea, they'll have symptoms of orthopnea, which is there. They'll have symptoms of paroxysm and nocturnal dyspnea, which is there. And they'll also complain that their breathlessness has been gradually increasing in severity. It is not getting managed with your inhalers. And even on examination, one critical finding which we'll always find sometimes is a raised JVP, which is there. So that is one clinical finding which will always point towards a right heart failure, along with your pitting pedal edema and hepatomegaly or ascites if it is a severe CCF. So these are the signs and symptoms which usually points towards a cardiac etiology in a COPD patient.
Thank you. Dr. Salvi, you can make your point and answer the next question. What are the clinical features and tests that help you differentiate between right heart and left heart failure? I think you're muted.
Very sorry. So before that, I just wanted to emphasize on one important point. Whenever a patient of COPD comes with an acute exacerbation, that's your diagnosis, an acute exacerbation of COPD. I don't think you should take that acute exacerbation of COPD at face value. Please look for underlying congestive heart failure. The patient may not be having an acute exacerbation. It may actually be an acute heart failure, which the patient is manifesting with. Second could be a pneumonia. Patients of COPD receiving high doses of inhaled corticosteroids for whatever reason are at an increased odds of developing pneumonias. So could be a pneumonia rather than acute exacerbation of COPD. And the third one is an acute pulmonary embolism. These three are very important differential diagnoses that you should keep at the back of your mind before you actually start your patient on treatment for an acute exacerbation of COPD. So I think that's an important message that should go to all the young pulmonologists listening to this. So how
Can I just interrupt and say that that's the Rome criteria, which was beautifully brought out. These are the three important differential diagnoses that you need to look for during an acute exacerbation of COPD, requesting all postgraduates to read the Rome criteria. Thank you, Dr. Salvi. Please go ahead. Sorry for interrupting.
Yeah. So left heart failure in patients with COPD will manifest with various signs, depending on whether it's a chronic bronchitic type of a COPD or whether it's an emphysematous type of a COPD. You will not get the classical basal crackles in emphysematous patients of COPD who have an associated left heart failure. So absence of basal crepitations does not necessarily rule out left heart failure. Right heart failure, I think you have to look at the JVP, which is a very important clinical sign that one must look for. Also look for pedal edema, which is these are crucial clinical pointers that will tell you whether it's right heart failure or left heart failure. Many cases, many a times, it's actually both biventricular failures. You have an element of right heart failure as well as an element of left heart failure. And then you actually have to treat both of them because the treatments are very different. Left heart failure, you have to give them a diuretic. Right heart failure is you need to reduce the pulmonary artery pressures by giving them adequate doses of oxygen, but being very careful at the same time. So I think it's important to at least understand the nitty-gritties of the comorbid states that can be associated, and then pick up each one of them and then treat them individually.
Dr. Christopher, did you want to say something? I thought you put your hand up briefly.
So sorry, no, I was just
okay, adjusting the. Yeah. So one of the things that we use in our ICU, for example, is to use point of care ultrasound. Look for B lines. You see B lines and you're probably heading towards a left heart failure. If you don't see B lines, you're probably dealing with right heart failure alone. Remember that things like NT-proBNP or BNP are raised in both, so it doesn't really help you. One of the things we used to do in the past when we did not have access to ultrasound is ask the patient to lean forward briefly for some time. If the patient with an acute exacerbation can do it, and crackles that were initially present disappear, that's a very good sign of early pulmonary edema. So But that's very difficult to do in a patient who is very breathless. So these days, we almost exclusively use point-of-care ultrasound. Dr. Christopher, Dr. Salvi already mentioned this briefly, but do diuretics, digoxin, and pulmonary vasodilators play a role in the management of patients with pulmonary hypertension, cor pulmonale, in COPD?
Important practical question, Murali. But before going to those specific items, I just want to give a quick overview of the approach to management, as this would be a question in the minds of many postgraduates and young specialists. We are bombarded with several pharmacologic agents, and we have to be very careful what we use in this situation. So the approach really is to treat the underlying condition well. So I'm talking very generally of the group 3 pulmonary hypertension. It may be COPD, which is what we are talking about. It may be ILD. It may be sleep disordered, breathing related. So whatever the cause may be, the first thing is to treat the underlying disorder well. In this case, COPD very well. If it is sleep apnea, give CPAP, and there is evidence that the pulmonary artery pressure drops, particularly with the use of CPAP in obstructive sleep apnea. The second thing is the supportive therapies. We know for chronic lung disease and even group 1 pulmonary arterial hypertension, we give them exercise as tolerated. I think we can be a little more generous. And if they are fit and able, they should go through pulmonary rehabilitation. They should have routine vaccinations, pneumococcal and influenza at least. They should be counseled and supported to quit smoking. And oxygen is used when indicated. And diuretics, when they are fluid overloaded, should be given. Now, let me point out the things that should be cautiously or perhaps should not be given. Anticoagulants are not given for group 3 pulmonary hypertension. So we should keep that in mind. And what is also not recommended is pulmonary artery hypertension directed therapy. That's what I had in mind when I said that we will be bombarded with a host of drugs for pulmonary arterial hypertension. So the challenge is to see what they are meant to treat. So agents such as the prostacyclin pathway agents like epoprostenol, tripoprostenol, iloprost, all that, or phosphodiesterase 5 inhibitors such as tadalafil, or endothelin receptor antagonists like bosentan. So all these are not indicated in group 3. They are indicated in group 1, but not in group 3. And there is even a chance that there could be harm by using them in this situation. So be careful. These are not meant for this group. I think so. Digoxin. So while diuretics are helpful, digoxin is not helpful in type group 3. So do not use digoxin for this group of patients.
Absolutely, completely agree. The only time that we use digoxin is when the patient has atrial fibrillation. You cannot use the beta blockers because things like sotalol are non-selective beta blockers. And you're always a little worried about somebody with structural lung disease using amiodarone in them, because if they develop amiodarone-induced toxicity, then you're in greater trouble. So that's one tiny group you may think of using digoxin. But otherwise, completely agree with you. And you gave us the most important message. Do not use the pulmonary vasoactive medications. They have zero role here and can actually be very harmful. Dr. Gayathri, coming back to you. Yes, Dr.
Yeah. So I showed you one slide where there were 4 sets of data. Patients of COPD with heart failure on short-acting beta agonist, long-acting beta agonist, beta blockers, and the anticholinergics. That study also showed what happens with digoxin. And digoxin does exactly the same as what short-acting beta agonists do. So please do not use digoxin in these patients. It may actually cause more harm. It's very tempting to write a digoxin when you say heart failure, but it's probably not appropriate in this setting now.
Absolutely. I think the most important messages have come out. No digoxin, oxygen, treat the primary cause, prevent exacerbations. And when a patient has a problem, diuretics, in my belief, are very often cosmetic, unless there is a lot of fluid overloaded state. In fact, we've seen patients with chest which is grossly waterlogged and they can hardly breathe because of that. It's behaving like a restrictive problem. So then definitely use diuretics, but otherwise be cautious. Using over-diuresing a person can actually cause greater problems also. Dr. Gayathri, how can healthcare providers differentiate between COPD exacerbations and left heart failure exacerbations? We already briefly discussed it. I think you can add something to that.
See, this is a very tricky situation when we see a patient coming with breathlessness in the ER. Does he have a respiratory component which is causing his disease, or is it a cardiac event? Do they call the pulmonologist or do they call the cardiologist, and who actually has to deal with it? Basically, some of the things we have discussed is that we have some background history. We can at least get, does the patient have any history of smoking? Has he had any inhaler use? So that may give us some idea that he had some kind of a chronic illness going on, and this could be a part of that illness proceeding forward. And as Dr. Salvi also mentioned, we also have to keep the other differential diagnosis of, is it only a COPD exacerbation, or is it a complication like an infection, or is it another really sinister complication, something like a pulmonary embolism? We have to keep all those things in mind also when the patient has come into with a breathless situation. It's not only a COPD exacerbation. And in terms of someone with a cardiac failure, some of the symptoms are very similar to that of a person with COPD. They still might be having a cough. Sometimes they cough, usually they say it might come only in the night or more in the lying down position, but sometimes it really doesn't matter. The patient might be coughing otherwise. And some of the features might be even that of pulmonary edema. He might be coughing out some mucus. So still it might be in a dilemma for us. What are we actually dealing with? So when you come on to the investigations also, this is a little bit iffy, because doing a chest X-ray, we might find out some infective change. But if it's going to be a left heart failure, we might see some bilateral perihilar opacities. So it's not going to give us any more additional information. And doing investigations like the NT-proBNP, in both conditions, it might be elevated. But in cardiac failure, the NT-proBNP is extremely high. So that is something maybe more than 15,000, 30,000. So that gives us a clue that we are dealing with something like a heart failure, and that should be managed as a priority. And some really newer tools which are come into play for us in the ER itself is the point of care ultrasound. You look for B lines, fluid overloaded, it's more towards the cardiac. Nothing like that is more towards the COPD. So these are some things which we really see. And sometimes we might have a combination of the illness happening. A patient with COPD might develop a cardiac problem. So we have to keep both in mind and keep our eyes open. So sometimes it's not which came first, it's not the egg or the chicken. It might be either.
Great. Thank you, Dr. Gayathri. Dr. Pragati, we already referred to arrhythmias, but can you tell us in a little greater detail what are the common types of arrhythmias in patients with COPD, and how do you manage them, including prevention of these? Dr. Pragati, are you still with us?
Yes, sir.
Okay, so I'll go on to Dr. Athul Francis. Dr. Pragati, you're back. I think she's having problems. Yes, she is back online. Dr. Pragati, can you hear me?
Yes, sir.
I think she's having problems. So we'll go on to Dr. Athul. Dr. Athul, untreated arrhythmias in COPD, what are its clinical implications? What causes them? And very briefly, because we've already discussed drugs, what drugs precipitate these electrolyte imbalances that can worsen arrhythmias or cause arrhythmias?
So untreated arrhythmia, not just in COPD or in any other condition, it will always have a propensity, especially if it's a arrhythmia like an atrial fibrillation. There is always a chance of you getting a coagulatory disorder, or you getting a thrombosis, or there is a high risk of stroke which is there. So many a time in COPD, the problem is it's underdiagnosed. The arrhythmias are underdiagnosed. Even if you see arrhythmias like a multifocal atrial tachycardia, most of the patients are asymptomatic. But when it comes in an exacerbation, it is something which will add on to the mortality of the patient. So a prompt treatment and prompt identification of arrhythmia is necessary, because otherwise, if the proper care is not taken, patient can have a sudden cardiac death, he can have a stroke, or he can have an embolism episode on a later date if he's not started on prophylaxis. And secondly, the drugs causing, as we discussed already, salbutamol is something which can cause a tachyarrhythmia. Many times theophylline, which we use, theophylline is something which has a very narrow therapeutic index that can cause arrhythmias. Longer acting beta agonists like formoterol has also been shown to have risk of arrhythmia. Similarly, the roflumilast, which is an add-on drug if you're in later stages of COPD, it is also shown to be having a propensity to arrhythmia. Same with azithromycin. Many patients, we give azithromycin prophylaxis for 3 to 6 months. So that also is a proven risk for arrhythmia. Diuretics, because of electrolyte abnormalities like hypokalemia, can also cause it. And many times for atypical coverage, when we give levoflox also, that also has a propensity for QTC prolongation. So these are the various things that can cause arrhythmia, and early identification is extremely necessary, especially if a patient is in atrial fibrillation or something, because in exacerbation, when the patient comes, the atrial fibrillation may be so severe that you might not be even able to save the patient. So prompt identification will really help in such cases.
And of course, atrial fibrillation, when it occurs, can often push a person into failure. And then you don't know whether you're dealing with the exacerbation. Something which starts as an infective exacerbation can end up with a left heart failure, given these complications. Dr. Sundeep Salvi, do beta blockers have a role in patients of COPD? You already showed us some data, but specifically, is there any specific beta blocker? Would you choose a beta blocker different beta blocker for different indications? And what are the advantages and disadvantages?
So cardioselective beta blockers are the ones that need to be selected. If you select non-cardioselective beta blockers, there is a potential to cause some element of bronchospasm. And therefore, it's crucial that you select only a cardioselective beta blocker. So something like a metoprolol would be an ideal drug that we can use for patients of COPD who require a beta blocker. I don't think there's much difference between the different types of beta blockers that we can use. You can choose the one that you are more comfortable with, but as long as you're selecting only a cardioselective one. I think there's nothing much, but the main carry home message that I really want all of the young pulmonologists to take home is, do not deny a beta blocker to a patient of COPD with an associated heart disease. The risk of this patient dying is high, very high. So, I mean, mortality would be then directly attributed to the doctor who has not given them a beta blocker. I think it's as important as that. I think it's important to realize that.
I take a little issue with the calling metoprolol a selective beta blocker. It is a selective beta blocker, but it's not a highly selective beta blocker. A lot of our patients, especially those with asthma, are given beta blockers, and it's said that they are a highly selective beta blocker. So be careful. I think nebivolol and bisoprolol are safer than metoprolol. I'm not saying you shouldn't use metoprolol at all. There are benefits for it, but I think bisoprolol and nebivolol are extremely good drugs, and those would be my first choices. Otherwise, as you said, there's really no difference between one beta blocker and another. Dr. Christopher, patients with COPD already refer to sleep disordered breathing. So what are the kinds of SDB, sleep disordered breathing, that these patients with COPD can get, and how would you manage these?
Yeah, I think this is an important question, as COPD is associated with the entire spectrum of sleep disordered breathing. I would start by something that is missed, which is sleep-related hypoxemia. COPD patients get hypoxic at night. They come to the clinic during day and their saturations are great, but that may not be the case when they sleep. So this is something we need to be aware of. And they can develop obstructive sleep apnea, central sleep apnea, respiratory effort-related arousals or RERAs, sleep-related hypoventilations. Two important statistic which I did not know, that 22% of COPD patients in a study had restless leg syndrome. We don't think of these things. And another very important but very practical point, 29% have insomnia. We hardly even think that's a sleep disorder disease, but a lot of them have insomnia for various reasons, including the COPD symptoms. Contributing factors, COPD patients are obese also. A good proportion of them are obese. That's a factor. Then smoking is a factor. Smokers have higher risk of sleep disordered breathing. Heart failure, which they are prone to, can cause central sleep apnea, chain stroke breathing, and all the gamut of things. And another factor that's important is opioid use. Now, opioid use is less in our country, but used for symptom control in developed countries. So all these factors could contribute to increasing the prevalence of sleep apnea. How do we manage them? If patient has nocturnal oxygen, if patient has sleep-related hypoxemia, they can have oxygen at night. Otherwise, most people with sleep disordered breathing, obstructive or central sleep apnea will use CPAP and benefit from it. We should judiciously consider BiPAP in patients who are CO2 retainers, who may tolerate that better than CPAP. Of course, the other measures such as weight loss and other factors certainly are important.
And controlling the underlying cardiac failure and respiratory.
Yes, absolutely. Absolutely.
So thank you. That's very comprehensive. Dr. Gayathri, we spoke about beta blockers, but the other big drug used in heart disease is statins. So do statins have a role in patients with COPD? And if so, which statin? Are there any specific subgroup of COPD patients in whom you'll prescribe statins?
See, all these days we've been talking about statins to be used for lowering the cholesterol in patients. So it was more favored for patients with cardiovascular disease. But with the relation to the use in patients with COPD, it's more of this anti-inflammatory properties which is actually being emphasized. The way it can decrease the CRP levels, how it can decrease the IL-6 levels, which are all inflammatory mediators in the mechanism of development of COPD. So this is what is being emphasized in the role of statins to be used in COPD. And basically also it's like something like an anti-thrombotic effect. It can have an effect on the endothelial response. So basically they're trying to emphasize that it can be also used to prevent the development of PAH. So that's also being emphasized, and why should we use a statin in a patient with COPD? And some of the studies have emphasized that it has improved the lung function. It has caused decrease in all-cause mortality. So all these things have been emphasized, and drugs like atorvastatin and rosuvastatin have been propagated and emphasized to be used in patients with COPD. So with the number of studies highlighting this, I also came across when I was looking about your question that one of the studies also mentioned that that was not the case. So the jury is still out on this. I can't say that we can make a standard recommendation. Okay, give everyone a statin, they'll be fine, they'll improve the lung function, and they'll live better, and they'll not have PAH. I think it has to be taken with a pinch of salt.
Well said. I think two things. One is when you have an indication, primary indication for statins, And we spoke earlier about the overlap between heart disease and lung disease, including coronary artery disease. Definitely use statins. Do not use statins for wrong purposes. We know that statins don't prevent exacerbations. So do not use it to prevent exacerbations. And as you said rightly, the indications seem to be that it improves lung function. There are good studies showing FEV1 improves, including a Cochrane review. It improves FEV1, it reduces inflammatory markers, but it did not seem to affect all-cause mortality. So that is the hardest endpoint we have and did not seem to make a difference in patients with COPD without heart disease. So use it for the right indications, be cautious in others, but it's a good drug. And I think, given its pleiotropic effects, we should really be considering it in patients with COPD. Dr. Pragati, we lost you for some time. We have you back. Dr. Salvi, before we
If I
go
can just add one point over here. Vitamin D is a very important vitamin for patients of COPD. And we know that when you lower the levels of cholesterol, the vitamin D levels also go down. So it's important to realize that. If you've started a patient on a statin, keep a watch on the vitamin D levels, because we know that vitamin D has a very important role in lung function, especially in COPD patients.
Great. Dr. Christopher, if you have to log off, please, but we'd love to have you for as long as you can stay. I think he's got to go somewhere. So going back to Dr. Pragati, does pulmonary rehabilitation for patients with COPD help in reducing the heart disease? We know it helps with lung disease, definitely. But what is its impact on heart disease?
Sir, in heart diseases, the pulmonary rehab improves the exercise capacity. It decreases the strain on the heart. The other way of decreasing the strain in the heart is enhanced oxygen utilization. It slowly helps in weight reduction. There is one psychological effect, that is decrease in the anxiety and depression. Again, that has a reduced effect on the heart load. And generally, we advise rehabilitation as early as possible during an exacerbation. ERS and ATS has advised that. And long-term rehabilitation, if it is done, then it improves the survival rate, and also it decreases the hospitalization, the recurrent hospitalization. So these are the advantages of pulmonary rehab in a heart-strained pattern in a COPD case.
And there's good evidence that actually it's the most cost-effective way of treating patients with COPD. And perhaps, from what you're saying, we should be calling it cardiopulmonary rehabilitation rather than pulmonary rehab alone. So I'll invite Dr. Salvi to come up with a new name other than Prabal, which you had some time ago. Include the heart also in that, Dr.
Absolutely. Absolutely. I think it should be cardiopulmonary rehab. All patients of COPD must have a cardiopulmonary rehab.
The last two questions we're coming to. What emerging therapies are being researched to address the COPD and cardiovascular complications that occur so often together? Dr. Athul.
Yes, sir. So basically, when you are talking about newer therapy, so basically the newer cornerstones of therapies of COPD, which is a triple inhalers, which is ultra LABA, LAMA, ICS, all of those are being designed keeping in mind the cardio safety profile as well. So if you are looking at the impact trial or the summit trial, they have all the other trial, the ethos trial. So they have always kept that cardio safety is something which is very, very important. So the triple therapy, the single inhaler triple therapy, along with inhaled corticosteroids, it has shown that it has a benefit in reducing the cardiac events as well, especially when it's initiated within the first 15 to or within 1 month of a severe exacerbation. So other than that, per se, when we are looking at COPD, we have other molecules which are coming up like ensifentrine, which is a combination which acts on both your phosphodiesterase 3 and 4, given as an inhalational therapy, which is also shown to have a better cardio safety profile compared to your roflumilast or theophylline, which are there. And the other things are basically your biologics, which are also being now approved for COPD, or dupilumab, etc. So these are the emerging therapies in COPD. So as such, combined of COPD heart, there is no therapy or innovations which we can say. But the recent innovations in COPD are mostly focused on treating the comorbidities or preventing worsening of the comorbidities as well.
Great, thank you. Last question. We started with Dr. Salvi. We will end with Dr. Salvi. does the stage or severity of COPD correlate with the probability of heart disease?
I think the answer is very much yes. As the severity of COPD increases, multiple things happen. The hypoxia increases. So increasing hypoxia will have a increasing impact on heart function. As the severity increases, you need to give them more drugs. So these patients are, in a way, over-treated with bronchodilators because it's a necessity for them. And I've just shown you data that beta-2 agonists, when given in excess doses, can actually have a detrimental effect on the heart. So that would be another contributing factor. Third is the bronchodilators also cause ventricular perfusion mismatch because some of them can also cause vasodilatation of the pulmonary vessels, and the shunt then becomes bigger, and so you get more hypoxia with medication. So it makes more logical sense that as the severity increases, the odds of having an associated heart disease also increases. But having said that, I think it was you or Professor Christopher who said earlier that even in mild cases, I think you said, even in mild cases of COPD, you will find cardiac disease states as well. So do not be under the false impression that mild COPD will not have a underlying heart involvement. So it's important to, as I said earlier, every patient of COPD must be examined for an underlying heart disease. It's crucial. It's an important, perhaps more important part of your treatment than the treatment of your COPD itself.
Great, thank you. Let's go to some of the questions from our audience listeners. Dr. Nusayba, this is specifically for Dr. Salvi, I think. The study showing the effect of formoterol and salmeterol on the heart, was it through the inhalational route, she asked?
Right. Yes, absolutely, through the inhalation route. I'm not aware of any oral medication or an IV medication of formoterol or salmeterol.
Yeah, I think inhalation would include nebulization, and this is the inhaled route. I'm also not aware of any other PrEP. Any of the panelists can comment on that if there is any non-inhalational availability of formoterol or salmeterol. Don't think so. Okay. No. Some of the other questions, Dr. Rida Khan has asked, how does the pathophysiology of COPD contribute to cardiovascular complications? We've discussed that. Treatments for COPD interact with medications commonly prescribed for heart conditions. Dr. Rahul asked. It's, I think, already answered. Dr. Ashwati says, what an excellent and eye-opening presentation, sir. That's for Dr. Salvi. Thank you so much for this lucid session. Dr. Jyoti Kini asks, most of our COPD cases have dyselectrolytemia, and she lists medications like diuretics with structural heart disease, dilated cardiomyopathy. But she also brings out an important point. She says the risk of malnutrition and deficiency of micro and macronutrients with decreased exercise, is it responsible for overall death? And I know this is one of her interests. She's doing some research on that. So any of our panelists, would you like to take that question? The role that malnutrition, undernutrition, micro and macronutrient deficiency plays in worsening COPD and its complications, including death. Great question.
I think it's an absolutely brilliant question. I think we have been neglecting this component of the treatment aspect with our patients. We have not understood the value of proper nutrition in patients of COPD. Most of the emphasis is on giving them symptomatic relief. But it is important, because they get a lot of steroids, they get a lot of other drugs. They don't eat well because of feeling short of breath. So most of them are usually undernourished. And that itself contributes significantly to worsening of the COPD. In fact, frailty is one of the very important predictors of exacerbations of COPD as well as mortality. So it's crucial to understand that and to take active measures against it. So dedicate a certain amount of time in from your treatment aspect of giving some importance to nutrition. And especially micronutrients are also important. Antioxidants. I generally like to give N-acetylcysteine to my patients of COPD because the antioxidant effect of it actually helps in reducing the subsequent exacerbations. So it's important to have an understanding of all of this.
Absolutely. And it's an important part of the pulmonary rehab program also, to get the dietitian, nutritionist involved. And I think that's a very, very important part of it. These patients, Dr. Christopher emphasized that a lot of them may be obese, but along with obesity, they also have sarcopenia. And that's a terrible combination. Obesity increasing inflammation and sarcopenia making it more difficult for them to breathe, making them insulin resistant. So that's a very, very important question, Dr. Jyoti. Thank you so much. Did anybody else want to add anything to that? I know Dr. Pragati was talking about pulmonary rehab earlier, and she made a very important point. I forgot to emphasize it then, that you need to start it early rather than late. And she mentioned, when patients are too weak to do pulmonary rehab, is not the time to bring it in. You have to bring it in early enough. And in fact, ideally, you should start it when a patient is symptomatic. And that's the stage where you introduce nutrition also. Great question, Dr. Jyoti. Thank you.
There's a very nice study, Dr. Mohan. Pulmonary rehab, soon after an acute exacerbation of COPD, when started in the first 30 days, has a significant impact on long-term outcomes. So don't wait for the patient to settle down, feel better, and then think of starting pulmonary rehab. In fact, you should start pulmonary rehab sooner than later, as you very rightly said that.
Absolutely. Dr. Gaurav asks, which single inhaler triple therapy is the most effective? Dr. Athul, do you want to take that?
Yes, sir. Coming to the effectivity of single inhaler triple therapy, I don't think there are many cross-on studies between different molecules of triple therapies. Whatever studies are there, your impact or ethos which are there, it's comparing your triple therapy with your dual therapy, like your LABA-LAMA or LABA-ICS. So basically, as here, because we are talking about cardio safety, vilantrol containing molecule is more cardio safe compared to a formoterol containing molecule. And although both the molecules which we usually have currently is formoterol-glycopyranate budesonide, as well as a vilantrol, imiclidinium, and fluticasone combination, as well as a formoterol fluticasone combination along with glycopyranate. So all these molecules have shown that they have decreased exacerbation frequency, decreased the fall in FEV1, decreased all-cause mortality as well. Although there has been incidence of pneumonia in the impact study has shown that there has been a slight increase. But overall, there are no head-on studies comparing different molecules. But compared to LAMA-LABA or a LABA-ICS, a triple therapy has shown beneficial effects if we are starting it in the right patients. That is, if your eosinophil count is greater than or equal to 300, or if you had one severe exacerbation requiring admission, or greater than or equal to 2 moderate exacerbation. So the right choice of patient is really important when starting a triple therapy. And especially if a patient has a mycobacterial infection, you can't start a steroid or a triple therapy there. So more than which is more effective, your ideal patient selection is which is more important, I feel.
And of course, your choice of whether you want to use a DPI or you want to use an MDI with spacer. Dr. Salvi.
Just an important point. The steroid component in the single inhaler triple drug combination should be kept at its lowest. So choose a combination that gives you that freedom to play around with the steroid dose. At some point of time, I prefer to even withdraw the steroid altogether, because the risk of pneumonias in patients of COPD receiving an inhaled steroid is really high. Don't underestimate that. So keep the steroid dose to the lowest. I think that should be an important component of the decision as well.
Absolutely. And always consider whether you can downscale it to a LAMA-LABA combination. Very, very important. There's a tendency to start it and never take the person off it. I think some of the other questions have been answered already. How does COPD increase the risk of mortality? How would you manage a patient with COPD patients with atrial fibrillation, symptoms and signs of heart failure, emerging therapies, including biologics? This is an interesting one. Dr. Gayathri or Dr. Pragati, whichever one of you wants to take this. What lifestyle modifications can COPD patients make to reduce cardiovascular risk? Shall we start with Dr. Gayathri?
I think the main thing is stop smoking. That should be emphasized. And the other thing, if they are obese, they have to reduce weight. And also to do a little bit of exercise, the breathing exercises, maybe as what emphasis was done on pulmonary rehabilitation started earlier itself, when they're not too ill to do any program or continue the program. I think that's really essential. And also top up the nutrients in their, I would say, a better nutrition to be followed for them, because sometimes it becomes that they become so cachectic and ill. So it's sort of difficult to get them to recover from their illness. So these are some things which we really should emphasize for our patients. And the correction of vitamin D, which Dr. Salvi also mentioned, in addition to all those cholesterol lowering agents, which can be added if they have a comorbid tendency for cardiovascular disease as well.
Excellent. Dr. Pragati, you wanted to add something.
We need to control diabetes and hypertension simultaneously, because they are also again leading to cardiovascular risk. So optimization of hypertension and diabetes should be the need of the hour, together with the COPD treatment.
In fact, that's interesting. We were just having a meeting the other day, an ICMR meeting, trying to push COPD out as part of the public NCD program. And one of the things we commented about was many of the factors that we use for the other NCDs, what you just mentioned, diabetes, hypertension, coronary artery disease, are all the same things that you'll push for COPD also. So these are actually an overlap of conditions, and something that Dr. Salvi mentioned earlier about how this, is a condition of multimorbidity. And in fact, I think you'll probably remember, Dr. Salvi, Dr. Klaus Rabe and Fabry came up many years ago with the statement that COPD should be retitled chronic systemic inflammatory syndrome. So that's actually an interesting thing. It is a systemic inflammatory syndrome. Yeah, you wanted to say something, Dr. Salvi.
I just wanted to add something. So COPD patients with diabetes, there is now good literature evidence to suggest that metformin seems to be a drug of choice, rather than giving them insulin secreting or insulin mimetic drugs. So good evidence that patients of COPD with diabetes, metformin.
Absolutely. And we wait with bated breath to see what the SGLT2 inhibitors and the GLP analogs will do, because they seem to again have multiple functions. Dr. Ganesh has asked three important questions, something that we didn't adequately address. What role does patient education play in improving the outcomes of individuals with both conditions? Very interesting question. Any one of you, whoever would like to take it. Patient education in patients with both heart disease and lung disease, COPD basically.
So I'll take the question, not just the patient education, the education of the relatives as well, I feel. So that is very, very important, because a COPD is something which is a progressive condition. So many a times there are patients, supposedly I had a patient in OPD who is a known case of COPD since 4 or 5 years. But he was a chronic smoker, everything. Currently he's 75 years old. And he wasn't aware of his COPD. Now he's feeling breathless at rest. And currently, when he came to OPD, his saturation is 75%. And he has not taken an inhaler his whole life. So now his thing is he doesn't have an exacerbation or anything, but his baseline saturation is currently 75. So educating the patient in such cases is necessary, because many times they require a long-term oxygen therapy as well. And also educating regarding the nutrition which has to be maintained, because most of the COPD patients in their later dates are malnourished. So nutrition is very, very important. And also, I think educating them regarding the vaccinations, your pneumococcal, your influenza, the shingles vaccine, whichever has come up in recent recommendations, that also is very important, because there are studies which have showed that it prevents life-threatening exacerbations. So that is also necessary. So patient education, not just giving an inhaler, but patient education is equally important here, because it's a chronic condition. It is associated with a lot of comorbidities, and morbidity is very high. Rather than the mortality, which is the final stage, the morbidity is very high. And especially for the relatives who are catering to the patients, that for them also appropriate counseling is needed as to how to care for the patients.
Yes, Dr. Salvi.
If you can just add, I mean, palliative care is also an important component, and palliative care, depression, and who better than you, Dr. Murali Mohan, to at least talk about it for a minute.
Yeah, so I think two very, very important things Dr. Salvi has mentioned. The first is the high prevalence of depression and anxiety in patients with COPD, often not addressed. We don't even look for it. We did some work 20 plus years ago where we found that 95% of patients with COPD have significant depression, mild depression, but significant, measurable, and about 40 to 45%. And this is not only our study, studies across the world have shown that moderate to severe depression occurs in up to 45% of patients with COPD. It gets worse the worse the COPD is, but is present even in those with mild COPD. In some, the depression is improved by smoking, so they continue to smoke and therefore develop COPD. In others, the COPD has a direct effect on it. And addressing this is a very, very important part of it. And incidentally, pulmonary rehabilitation plays a role in reducing the depression also, something that Dr. Pragati was mentioning earlier. The other point that Dr. Salvi has brought up, very, very important, is think of palliative care. Palliative care again kicks in. It's not end-of-life care. Palliative care kicks in when the patient is symptomatic. So when a patient is symptomatic, start thinking how you can reduce the severity of his symptoms or her symptoms. The other point, which I think Dr. Alvar Agusti has been bringing up, and I think is relevant to many conditions, is the concept of treatable traits. So when you see the patient first, what are the traits that this patient has that you can actively treat? And that's a very, very, very important thing. As much as putting a label on the patient is important, he has been promoting this idea that looking for treatable traits is important rather than just trying to put a label on the patient. So those are things that we need to do. I would strongly urge all of you to start thinking of A, pulmonary rehabilitation early in the disease, B, palliative care when the patient is becoming more and more symptomatic, and ask yourselves a surprise question. Would I be surprised if the patient died within the next 6 months or 1 year? And if the answer is no, I would not be surprised, initiate end-of-life care and the end-of-life discussion, because we have lots of patients who end up in the ICU on a ventilator when they should never have been in the ICU or on a ventilator. Have these discussions with the patient and their family quite early. Important point that Dr. Athul made earlier. Talk to the family. The caregiver is as important a component of the care of a patient with COPD as the patient him or herself is. Another very important question Dr. Ganesh has asked, how do socioeconomic factors influence the incidence and management of COPD and heart disease? Dr. Salvi, you're our person who does the maximum work on epidemiology, so I'm going to go to you on that.
Yeah. So social poverty is an important risk factor for COPD itself. And because of poverty, you're more likely to be exposed to tobacco smoke, more likely to be exposed to higher levels of indoor and outdoor air pollution, which again then has an impact on the cardiovascular health as well. So, poor socioeconomic status is the major strata where you will find a lot of COPD patients who are in the moderate to severe category or very severe category, and most of them will have associated cardiovascular ailments as well. So yeah, it's important to focus more on them. There's no question that this is an important targeted population or population at risk of COPD and associated cardiovascular disease.
And
They
again,
don't get adequate treatment. They're on oral medication that compounds the problem as well. So there are a lot of things. So there's a lot of patient awareness and education, community awareness and education that needs to be undertaken.
And one of the points that you made, that air pollution, the PM 2.5, is as highly associated, if not more highly associated with cardiovascular disease as with lung disease. So
Absolutely.
that's something we should not forget. And Dr. Ganesh has another very important question. He says, which inflammatory markers are more indicative of cardiovascular risk in COPD patients? I'm going to go to Dr. Gayathri on that. Inflammatory markers most indicative.
I think one of the common inflammatory marker we have is CRP, which we do for patients. I think that would be a marker which we can see whether it's going to be elevated. That is one of the things. The other markers which we do have in the fray, all those IL-6 and all that, we are not doing that on a regular basis. I think all that we did it at the time of COVID at a certain point of time, but we didn't really pursue doing it subsequently. I think that's one of the things we can do for our patients.
And of course, all our patients with COPD should have their lipids assessed, which includes the extended lipid profile at least once. So I think that's something. And what Dr. Pragati mentioned, look for diabetes in them. So a lot of them have impaired glucose tolerance, even if they don't have frank diabetes. There's a very high overlap between COPD and diabetes. So I think we have to look for those as markers. Dr. Deeksha has a very interesting question. Yes, Dr. Salvi, please.
Yes, I mean, a routine hemogram could also be a very useful biomarker. So if
Absolutely.
the hemoglobin counts are high, you know that there's an element of significant hypoxia that is contributing. Look at the WBC count. A high WBC count would probably indicate an underlying chronic infectious state. So maybe antibiotics, long-term antibiotics. You know, those are the sort of benefits of doing routine biomarkers that we.
Dr. Deeksha has a very important question also. How might the respiratory microbiome impact both COPD progression and cardiovascular health?
If I can, yeah. So one of my PhD students did look at the microbiome in patients of COPD, smoker COPD, biomass smoke COPD, and clearly the non-smoking COPD, the biomass smoke COPD have a much greater disturbances in their microbiome, in the sputum microbiome. There are more pathogenic bacteria in these patients, and I'm not aware of anybody having looked at lung microbiome and its impact on heart health. Probably there must be something happening in that space as well. But as of now, I think the only application is from a research perspective. I don't think there is any therapeutic potential of having that knowledge that will be useful. But if you have a much more disturbed microbiome in the sputum, you're more likely to get repeated bacterial infections. So I think that's the only application.
And of course, this is a special interest of mine. I've been developing an interest in the gut microbiome also. And remember that these patients get repeated courses of antibiotics, which completely disturbs the gut microbiome. And the dysbiosis in the gut causes the same problems in the heart and possibly also increases the inflammation systemically, not just in the lung, but systemically. And that's a big problem for patients. It causes neurological issues, it causes cardiovascular issues, but also causes a significant amount of muscle wasting and weakness. And that's something we need to be very conscious about when we use antibiotics in these patients. And I think there are enough studies showing that within 2 days of a patient entering a hospital, the oral microbiome completely changes. And we know that the oral microbiome has a big impact on, again, atherosclerosis and cardiovascular disease. So that's, there's a lot of stuff coming out. Watch the space, I'll say. As Dr. Salvi said, we don't yet have enough data to make recommendations. We may have, by the way, we have more than 1,800, close to 1,900 logins, which is amazing. Brilliant panel. Thank you so much. Dr. Ankita asks, what role does oxidative stress play in the relationship between COPD and cardiovascular disease? And I know that's Dr. Salvi's pet topic, so I'll invite you to come in first.
So we talked about it, and I did mention the role of N-acetylcysteine as an antioxidant rather than a mucolytic in patients with COPD. So you need to give them at least 600 milligrams twice a day. Once a day does not work, as shown in the very large bronchus trial. So if you want to give them a reasonable dose of antioxidant, then N-acetylcysteine at least twice a day. There is good evidence to support the role of antioxidants in the management of COPD.
Great. Anybody else wants to come in on that? If not, Dr. Amita asked us to go on till 10:45 as there were so many logins. There's only one question. I'm not sure I understand. I certainly have no answer for this. Any of you want to take this, you can. Dr. Gunjan asks, any neurotransmitter useful in COPD?
I don't know what it means, but I can tell you based on the scientific evidence, isoprenaline is cardiotoxic, so most certainly should not be used in patients of COPD. Adrenaline was a very popular drug that we used to use for acute asthma exacerbations. Again, it has got significant cardiac side effects, so adrenaline should not be used. Other than that, I think the routine beta agonists and beta blockers and associated heart conditions, those are the only drugs that come to my mind.
Great. Right. I think we've finished all questions. Had many, many more questions apparently, but we're running out of time. I'd like to end by requesting each of our panelists to give us a one-line message, one key message that you want our listeners to take home on the issue of COPD and the heart. And I'm going to start with in reverse order. Dr. Athul first.
Yes, sir. So one thing here when you're talking about COPD and heart disease, one important thing is early identification. So early identification of a heart pathology is very, very important. Many of the times what happens is we diagnose it during the time of exacerbation, and many a times that time has gone in which you can intervene actively. So at least a ECG or just looking at basically his pulse rate for a moment when he comes for the follow-up can be very useful. So early diagnosis of a heart pathology in COPD can go a long way in decreasing mortality due to a cardiac cause in COPD.
Great. Dr. Pragati?
Sir, I would always stress on pulmonary rehabilitation, sir.
Very good.
It works wonders for all patients who are in a hospital and during exacerbation. I would never feel I feel full when I'm advising rehabilitation. So
And I think the right word,
yes,
Dr. Murali Mohan, is cardiopulmonary rehab,
yes, sir. I'll
not
change
pulmonary
that word.
rehab.
Yes, sir.
Great. Thank you. Dr. Gayathri?
I'd really like to emphasize and counsel the patient to stop smoking, both for the cardiac point of view and for the respiratory point of view. And also emphasize the importance of vaccination, because I find both the conditions, the COPD and the cardiovascular disease, those patients with decompensated cardiac failure and heart failure, they need to be vaccinated. And many of them have so many misgivings about getting vaccinated. So they come back with an illness, and sometimes we find out it's an influenza which precipitated all those things. It seems to be so heartbreaking to see that it was a vaccine preventable disease which caused so much of morbidity and cost and expenditure in the ICU. So I like to emphasize counsel for smoking cessation, emphasize on vaccination.
Perfect. You emphasize that, just an ounce of prevention is worth a pound of cure. And you use the right term. I think it's heartbreaking to see something we could have prevented, which we've not done. Thank you. Dr. Salvi, last word with you.
Yeah. So every patient of COPD must be investigated for an underlying heart disease. Do not leave a single patient. Be very careful when you use beta adrenergic agonists in the treatment of COPD, especially those who have an underlying ischemic heart disease or a heart failure. And finally, do not deny a beta blocker to a patient of COPD with a heart disease. I think these are my key carry-home messages. And perhaps Dr. Murali Mohan, I mean, yours would be the last word of your key messages.
To extend your message, educate your cardiology colleagues to please look for COPD in their patients with coronary artery disease. The last word I'm going to leave with Dr. Renu. She says, wonderful webinar. Really learned a lot from this. Thank you, ICS, for organizing this wonderful discussion. So, panelists, fantastic discussion. All of you added so much to everyone's knowledge. Thank you so much. And we look forward to the next week's ICS webinar. Good night, everyone.
Good night. I would like to, so let me also thank Dr. Murali Mohan for moderating this session so beautifully, as always. I believe this is perhaps one of the most popular sessions. I think there are 1,889 who logged in right till the end, which is an amazing feat, isn't it? And thanks to Dr. Murali Mohan for driving the discussion so beautifully. He picked up all the key elements of discussion, and I think everybody contributed so beautifully. So on behalf of the Indian Chess Society, Dr. Murali Mohan, thank you so much for this tremendous webinar that we had. It was a wonderful learning experience for me as well, and all the panelists, Dr. Gayathri, Dr. Pragati, and Dr. Athul. I think it's been an absolutely marvelous webinar that we had today. So thank you so much. Once again, a reminder for the NAPCON in Pune, 23rd to the 26th of January. And I hope that all of you all would come to Pune to celebrate the specialty of respiratory medicine. So on behalf of ICS, I would also like to thank two people. One is Dr. Amita Nene, who has tirelessly been conducting these webinars as the head of the training programs of the Indian Chess Society. Every program that she has conducted has been absolutely a marvel, and so many pearls of wisdom in each of those programs. So thank you, Dr. Amita, for organizing such a wonderful symposium. And also,
And
since
again,
you-
like to say that, a lot of the questions came from Dr. Amita. I merely modified them a little. She did a lot of the hard work behind this.
Thank you, Dr. Amita, for that. And finally, we would also like to thank Lupin for the tremendous support for this specific webinar. So thank you very much to everybody, and good night. Have a peaceful sleep.
Good night, everyone.
Good night.
Special thanks to the tech team. They've done a great job here.
Absolutely. Yeah.
Thank you.
Thank you. Thank you.
Thank you so much for the opportunity for inviting us. Thank you so much.
Thank you. Thank you all.
Thank you, sir. So should we close this meeting with your permission?
Yes.
Thank you.
Yes, please close, Kushi. Thank you.
Thank you. Thank you.
Good. Aditi, the overall feedback has been good.
Yes, sir. Very nice. Getting a lot of feedbacks now. Tomorrow also, I'm sure we get usually on our chats, we get certain